Okay, we're going to welcome Dr. Marvin Schwartz as our next speaker. He is professor and head of the Division of Social and Community Psychiatry, director of behavioral health for the Duke University Health System, and director of the Duke AHEC program. Dr. Schwartz has been extensively involved in research and policy issues related to the organization and care of mentally ill individuals at the state and national level. He was a network member in the MacArthur Foundation Research Network on mandated community treatment, examining use of legal tools to promote adherence to mental health treatment, and led the Duke team in conducting the first randomized trial of involuntary outpatient commitment in North Carolina and the legislatively mandated evaluation of assisted outpatient treatment in New York. That is the longest sentence I've ever read in my life. Welcome, Doctor.
Well, thank you very much. I have the tough slot after lunch. What I'm going to talk about is probably a topic that some people come with some preconceived notions about, as in part because AOT, or assisted outpatient treatment, or involuntary outpatient commitment, sort of was the poster child for opposition to involuntary treatment. And for those of you who, sort of have a negative cast about thinking about this, I'd ask you to suspend your disbelief about the topic and let us walk through this, and also think about, in terms of the context of things we've been talking about the last day and a half, if I were to assert to you that involuntary outpatient commitment in fact operates as a less restrictive alternative to involuntary hospitalization, would you think about it differently? So let me go forth. And I want to thank a bunch of people in the room from the MacArthur Network who listened and collaborated with us on a number of these studies over the last 20 years. So what I'm going to talk about is, can assisted outpatient treatment be effective? Under what conditions can it be effective? Can it reduce arrests and criminal justice involvement? We may get into whether it's fair, but be happy to discuss that. And I'm going to present a little information on its cost effectiveness, which are new data that I think are kind of interesting. I actually got into this because, as a psychiatrist, I was working on an acute ward and in the prison system in North Carolina, which, if those of you who remember, Cool Hand Luke is a very similar type prison system. And, it used to really distress me and demoralize me and my patients to see the same people coming in and out of both the prison and the ward that I was running. And I recognized that we had this statute in North Carolina that permitted involuntary outpatient commitment, and so became interested in whether it works and whether it's effective. And that started a series of collaborations in which we've tried to pursue that question. What is it? It's a procedure whereby a judge directs a patient with a history of treatment non-adherence to comply with a court-authorized treatment plan. So the idea is that a treatment plan is presented to a judge so that it binds both the patient and the treatment system to a treatment plan. And I think many of the people who think about outpatient commitment think about it unidirectionally, as a judge ordering a patient to do something, when in fact our studies have shown, and other people's studies have shown, is that it also has an effect on the treatment system, making them prioritize the folks that are needing care. It's permitted in all but a few states. Now 44 states have it explicitly on the books, and the District of Columbia also has a provision. But it's used very infrequently, even within a state, it may be used variably across counties within a state. There's really three variants of AOT. A step down from involuntary treatment as an alternative to hospitalization for people who meet inpatient commitment criteria, or as an alternative status for people who aren't at the threshold of inpatient commitment and might be outpatient committed. North Carolina, New York, some of the newer states that have AOT on the books have this sort of third category of preventative statute. So before a person meets inpatient criteria, they can be ordered to outpatient treatment. In reality, however, the vast, vast majority of outpatient commitments are of the first type. So as a step down from an involuntary inpatient admission, and you'll see that in our data from New York. So the criterion in North Carolina, which is one of the states that has a preventative statute, that ostensibly averts a crisis, is the presence of a serious mental illness, the capacity to survive in the community with available supports, a clinical history indicating a need for treatment to prevent deterioration that would predictably result in dangerousness, and a mental status that limits or negates the individual's ability to make informed decisions to seek or comply voluntarily with recommended treatment. So most of the states since North Carolina recodified its commitment statute in the early 90s are similar to this. I mean, New York's is a little bit different in that it has more specific criteria, but they generally look like this. So some of the controversies about AOT really have to do with who's at fault in this. You know, is it the individual who's non-adherent to treatment, or is it really a lack of capacity on the part of the mental health system to meet the needs of the person who's non-adherent or non-compliant? And the corollary to that is that you're sort of blaming the victim in hauling the individual in front of the court and saying you need to comply with treatment when in fact the treatment plan might not have been appropriate to that person or inadequately resourced to meet the needs of the person. But I think a counter-argument you might make if you envision AOT to be like a mental health court, because in many ways it is similar, in which a group of people get together and construct a treatment plan and execute it. So given the apparent benefits of mental health courts that we talked about yesterday, in that it mobilizes resources for patients, should you need to commit a crime to get the benefit of that kind of stakeholder collaboration under the supervision of a judge? So if you think about it that way, it reframes how we think about outpatient commitment a little bit, or AOT. So the first study we did was an attempt to do a randomized trial of outpatient commitment, and this is the north central region of North Carolina. And what we did was negotiated with a lot of people to conduct this study, which Hank's group later did in Bellevue Hospital when New York first tried to pilot an AOT statute. But what we did is said, for folks coming out of the hospital with a AOT order, we would approach them and offer them an opportunity to participate in the study, in which they either receive case management plus AOT or case management alone. So what happened was that folks who agreed to randomization had a 50-50 chance of being released from a court order they already had, because they were leaving the hospital under an AOT, and what the experiment was randomization to be released from a court order. And then they were followed for a year under the court order plus case management or case management alone. So it was a study that was attempting to see, is there an additional benefit to the court order over and above the effect of case management and regular community services? And what we found in the straight-up intent-to-treat design in terms of rehospitalization, which was the major outcome measure, was that if you were in the outpatient commitment group, you were significantly less likely, the odds ratio is 0.64, so you were about a third less likely to be rehospitalized over the course of that year. And you see that too in terms of length of hospitalization, particularly if you got a longer period of AOT. So if you had 6 months or more of outpatient commitment, you had a significantly shorter inpatient stay of about 7.5 days as compared to 30 days for people in the control group, or around 30 days for people who got a short period of outpatient commitment. We also found that we had a group in the randomized trial, but we also had a group of patients who had been deemed violent, who we could not randomize because the clinicians weren't willing to randomize the folks who had been identified as violent. So we were able to still study that group. And what this graph shows you is that in the randomized group, if you had a longer period of outpatient commitment, you were less likely to have a period of violence in the follow-up period, in the year following that. Now, this is not the sort of violence that we're talking about in terms of gun violence. This is sort of the kinds of violence that happen in the lives of people with serious mental illness, pushing, shoving, or altercations with people. There was very few acts of severe violence here, but nonetheless it did reduce rates of violence, and that reduction also held for the people who had a prior history of violence, and so that's what that graph shows you. In addition, we found that if you got a longer period of outpatient commitment, you were less likely to be arrested. However, that arrest only happened among people who had a prior history of arrest. So if you'd never been arrested, it didn't prevent your first arrest. However, if you got a longer period of outpatient commitment and you had a prior arrest, you were far less likely to be rearrested. So what we find, we have a lot of other things we looked at in this study, and I won't go into them now, but just to summarize, what we found was that outpatient commitment in that randomized trial could reduce hospital recidivism, but it had to be applied for a longer period of time. So generally, the benefits accrued more if you had 6 months or more of outpatient commitment, but it was only effective if it was paired with frequent mental health services. So the court order in and of itself didn't prevent rehospitalizations and didn't improve outcomes. It had to be paired with frequent mental health services. Other outcomes that we found in the study were that outpatient commitment reduced violence, which you saw, victimization, which was more common, as you know. So it reduced rates of victimization in this population, kept them safer. Reduced family strain, arrests, and improved medication adherence and improved quality of life. But by and large, all those outcomes were attained only in a circumstance where the person had a longer period of outpatient commitment, 6 months or more, and got frequent services. If you got frequent services alone, you didn't necessarily get these outcomes, or if you had outpatient commitment and no frequent services, you didn't see the benefits. The two had to go together. So in this situation, the median number of services were 3 services a month. So you had to get, on average, more than 3 services a month. And actually, the average among those people was 7 services. So it wasn't, this was done in the 90s. So that we're not talking about assertive community treatment. We're talking more what generally would now be intensive case management. So now we're going to move to New York, which is the more so widely known and studied AOT system. And this was a study we did with Hank's group and Policy Research Associates, and was also many of the people, the MacArthur Network, helped us with this study. So this was a legislatively mandated study of AOT after it had passed several successive periods. So this was into the 5 years after it already had been enacted. So that's Kendra's law. The difference in terms of Kendra's law and any other outpatient commitment law in the U.S. is that when Kendra's law was passed, it came with 2 appropriations. One was an implementation appropriation of $32 million. So the legislature appropriated $32 million to create the infrastructure for Kendra's law. The AOT teams that supervised people, that made sure the treatment plans were being carried out, a bunch of things like that. So it's the only state actually that I know of that actually put money into the infrastructure of the new program like this, and at the same time appropriated $122 million into new services statewide as sort of the deal, the social contract about AOT. It was very, very controversial, and one of the ways it became palatable to people is it came with an appropriation for additional services that would benefit everyone in New York. So just to tell you a little bit about the New York program, it's largely a New York City program. And what you see here is these are counties. A dark blue county is a county that would have a high estimated or predicted prevalence of serious mental illness. So you would expect the most dots, which are AOT orders, to be in the dark blue counties. What each of these black dots represents an AOT order. So what you see is that most of the orders are really in New York City and Long Island. And then there's some other metropolitan areas that have higher rates. That's important in understanding Kendra's law because it was largely implemented downstate. Here's a graph that shows you the origin of the orders. And this is my comment about least restrictive alternative. If you look here, this is the origin of the orders. And the light blue are orders that originated in the hospital. The dark blue are orders that originated in a prison or jail. And the light clear color are the orders that originated in the community. De novo, started in the community. And you see 80% of the orders started as a step down from the hospital. So they were a way to, in effect, another form of conditional release for people who had been largely involuntarily hospitalized. And you see a relatively small number of people were coming out of prison. So overall, this is maybe 60 people statewide in this period of time. So it was not, we thought it would be a bigger phenomenon when we started the study, but it turns out it's not. And this looks like there's a lot of people coming out of prison getting ART orders, but note that this is just 29 people. So it's not a lot of people. Let me just, in terms of other outcomes, and I invite you to look at the report. The report's online at the New York Office of Mental Health website, and we also published a special section in psychiatric services, that covers a lot more of this. But what we found in our evaluation of Kendra's law in New York, what we did is looked at people prior to their AOT order and then themselves after the AOT order. We tried to have a comparison group, but it's almost impossible to match this group of people using administrative data because they've been carefully selected for Kendra's law. And so going to a database and pulling out people who you think are comparable is very difficult to do. So most of our findings are really pre-Kendra's law, for following people pre-Kendra's law, post-Kendra's law, and then using statistical controls to try to adjust for their propensity to receive the court order again. And so what you're seeing in these bar graphs are the results of very highly controlled estimates of hospitalization pre-post, using a lot of statistical controls. So what you see is that pre-AOT, the rates of hospitalization were about 14% a month for folks who would later get AOT. Following AOT, their rate of hospitalization in the first 6 months of AOT went down to 11% and then to 9%. In terms of inpatient stays, they also significantly were reduced from if you were hospitalized about 18 days a month to if you got AOT after the AOT order started in the first 6 months, 11 days, and then 10 days. And then in terms of receipt of medication, we used a measure that's called the medication possession ratio because we can't go out, we couldn't in this study go out and see who had medication and who was taking it. We used a technique in which you look at pharmacy fills, and that's called the medication possession ratio. And what we found is that folks who got AOT were far more likely to to be in receipt of appropriate medications for their condition. So this is the increase, statistically significant increase in receipt of appropriate medication after they received their AOT order. And then in terms of arrests, what we found is that the percent arrested by month prior to AOT and prior to receipt of intensive services, in this slide we do have a comparison group, they had a rate of about 3.7%. Once they got on AOT, the arrest rate went down to 1.9. However, you see that folks who also started on intensive services, in this case, they started assertive community treatment, also had a reduction of their arrests, although that was not statistically significant. So there was a statistically significant reduction in arrests. However, there was a trend in our comparison group in reduction of arrests. And then the final data thing I'm going to show you is a cost study that we recently completed. And what we did here is took all the treatment costs and all the administrative costs that we can identify for the AOT program. And what you see in the first column is this is the 12 months for an individual, the 12 months prior to going on AOT. And the costs here are, this is hospitalization. Okay. This is hospitalization in OMH, Office of Mental Health Facilities. This is Medicaid hospitalization, so we added those together. This is outpatient mental health treatment. This is medical treatment. This is criminal justice costs. And what you see in the pre-AOT period, the average cost per person was $104,000. Once the person got on AOT, the average cost went down to $59,000, and you see the main reduction here is in hospitalization. You see the compensatory sort of increase in outpatient services, which is what you expected. That's what the design of the study, the design of the program was, more outpatient, less inpatient. This is the cost of the program cost. And then up here is medical treatment, and then you see criminal justice costs. Criminal justice costs were not huge and didn't change all that much. I mean, it's a smidge. And then, so that's the first year, which is about a 53% decrease in cost per person, or in the aggregate too. And then in the second year, another about 12% decrease to $53,000. So not only was it sustained, the decrease, there was a little bit additional savings in the second year. So now one caveat about that is that, well, you say, gee, this is a great cost saving program. In the aggregate, you're saving money. One of the rubs about this that, you know, I think were reflected in the conversation this morning is you're saving money for one budget and you're spending money in another budget. So this is saving money to the, if you're saving Medicaid dollars, that's largely state and federal dollars. OMH is state dollars. The increase in outpatient might be also Medicaid, but county dollars. So it doesn't necessarily translate to everybody saving money. Someone might actually have to spend more money in order to achieve these overall total savings. So that's what the cost looks like. And we also...
But wouldn't that $122 million that they added when they passed Kendra's law be subsidizing the increase in the purple in the 12 and the 24-month thing? Would those, in fact, been supplemented by the money that they put out?
Yes. Yeah. And those would be state, by and large, be OMH dollars. Yeah. But a lot of that is Medicaid dollars. So those are the cost savings. We also replicated this And this is forthcoming in the American Journal of Psychiatry. We also replicated this in North Carolina because recall in North Carolina, which we'd done the similar study in the 90s, there was no appropriation. So the question we looked at in North Carolina is, if there's no appropriation, do you still have cost savings? And what we found was similar cost savings in North Carolina in a program that had not been received an influx of new funding. One other point about this is, you see, this is New York City, and we separately analyzed New York City and upstate because we showed you how different the upstate and downstate programs are. But the cost findings are virtually identical, upstate and downstate. So it's not a difference. We just, and this Hank insisted on this, we did those analyses separately because the programs are so different. So let me just wrap up. What we saw in the cost findings is that in New York, total costs declined 50% in the first year after AOT began, an additional 13% in the second year. Upstate, in the 5 counties that we sampled, there was a reduction of 62% in the first year and 27% in the second year. And so these costs were significantly reduced. The bottom line in the cost piece is that AOT can reduce overall net service costs, mainly by shifting patterns of service provision from inpatient to outpatient. In the New York AOT program did require a substantial investment of state dollars to provide the base of community services. So one of the caveats about the cost findings is this is one state, this is a unique program, and there were unique resources that went into this program, and so other states might have different results. And New York put the $122 million in now 7 years ago, and those dollars haven't increased, so it's sort of silted up in terms of people accessing new services, and so these results may not even hold for New York in the future. To summarize overall the New York findings, the program appears to improve a range of important outcomes for its recipients, including reduction in arrests. The increased services available under AOT clearly improve recipient outcomes, and I can show you some other outcomes, but there's a whole range of things that improve for people in the AOT program in New York. And a lot of that had to do with more services. However, we also found that the court order in and of itself created additional benefit. There was something about the court involvement, the monitoring of the program, that added benefit beyond just the effect of the services. And we've shown that in particular statistical analyses that, for example, where people who had AOT and ACT did better than people who got ACT alone. So if you take the premier evidence-based service, the court order still added additional benefit. And what we found was the AOT exerts a critical effect both on the patient but also on service providers to mobilize to address the priority population. Thank you.
Is any of this data stratified or type of mental disorder, diagnosis, the type of treatment, the type of drug used, the type of offense involved, or and does it include highly specialized release programs, such as those involving the use of cyclodextrin acetate for sex offenders?
Yes.
It's all lumped together.
These are all severely mentally ill persons, and who have not committed crimes. They're they've been non-adherent with treatment and received a court order. We are going to look at subpopulations within New York City in the near future. When we've done those analyses in North Carolina, we found that actually folks with schizophrenia benefited somewhat more than folks with bipolar disorder. There seemed to be a differential effect. To its credit, we did find that folks with dual diagnoses, so if you had a substance abuse comorbidity, you still did well.
Thank you. A fascinating presentation. I'm a lawyer. The full disclosure, I'm a lawyer and don't claim to have the ability to question the data. I am. I've spent quality time with your first study, and looking forward to spending quality time with your upcoming study. And I'm most interested in that little tiny brown portion of the bar chart that relates to what you call criminal justice costs, especially in the context of California's assisted outpatient treatment law called Laura's Law, which has an immense front load to it in terms of process and due process and court proceeding, and a back-end load of no authority on the part of the judge whatsoever. Not only can the judge not impose sanctions and rewards under our law, the judge can't even hold somebody in contempt. Somebody could hold up your middle finger to the judge in open court, and the judge could not hold you in contempt specifically. A very deep question with respect to rewards and sanctions under our law. What savings are we going to see, first in the criminal justice system as a consequence of assisted outpatient treatment? And what is the justification for the immense costs? We've had the law for 10 years. There's only one county that's implemented, a little tiny one, that big. What are the implications of the immense cost on the legal side of implementing assisted outpatient treatment? And where do the huge savings come in the healthcare system that would have to justify those costs?
Well, if you look at, if you had the same sort of experience, the savings would be on inpatient hospitalization. The savings are always on inpatient hospitalization because that's where the money is. This is a different population than a mental health court. So they just don't have as much criminal justice involvement, and so the savings, are not substantial there.
You got to make a distinction between criminal justice costs and court costs.
Right.
That's true.
Yeah, we have a huge, our assisted outpatient treatment law is immensely costly to implement. It's very costly to do one of these proceedings. I see about, in your set of criteria for North Carolina, I see maybe 4 hours of cross-examination. In our criteria, I see about 4 days worth of cross-examination. So it's much more intensive. Very expensive to do this in the civil court, which is the mental health court. Right. And I don't see where the savings are going to be in the criminal justice system.
Well, I think part of that is an artifact of the intent of folks who were opposed to AOT. I mean, I think in Laura's law, there were poison pills put into Laura's law to make it unenforceable. I would say in Kendra's law, it's far more, it's very difficult to initiate a AOT order. You have to get the certified hospital records from 2 hospitalizations within the 48 months. If mental health, the mental health legal assistance represents each client and sits in on the psychiatric examination. It's the civil protections that have been placed into these laws are an attempt to impede their use. And yes, you're right, it would be expensive, but those are the poison pills that were introduced.
Again, with our law, there's no sanction, there's no reward capacity that the judge has.
So let me address that. So a common criticism of AOT is that it has no teeth. It is not a program that's going to move and influence people who are desperately ill. I think it's a program that works with folks who can be engaged when they're nudged by the judge and they have the incentive of a good treatment program. But for people who are desperately ill, it won't move that. I mean, it's not a strong enough program with enough teeth to do that. We found in North Carolina that there was very little enforcement, the so-called pickup orders, which is, it's called a removal order in New York. They're very rarely issued, largely because, by and large, the people who are going to respond to AOT respond to AOT. And the other things that happen, like the case manager reminding them that the judge wants you to comply with the treatment. The family, we found the families reinforce that. The case managers, there's a whole bunch of people who are reinforcing the message that folks need to adhere to the treatment program. To me, that's the main mechanism of action other than the treatment program, right?
Not what the judge does?
No, what the moral authority of the judge.
What the judge does.
Yeah.
I think we need to be careful in dealing with this topic in the discussion, because this is a different topic than we've talked about the entire conference. In almost every state that I'm aware, when AOT or involuntary outpatient commitment is passed, it's because some criminal act, like Kendra Webdale, was pushed under the subway and killed. Laura's law, you'd have to inform me. It's a similar thing. New Jersey, every one of these had a homicide by a person who had been or should have been in treatment. But the reality of what the program is, it is not a program of decriminalizing. It's, in fact, dehospitalizing. It's a way of cost savings on the civil side. And most of the issue, it's civil court cost, it's civil hospitalization, and that's what this program is. It's not a criminalization program, despite the fact that when the statutes are developed and passed, they're usually some high visibility criminal act. It's a very distinct minority of what happens, and the reality is, how do you save money and how do you get people into treatment who deserve to be in treatment, who in fact have been excluded from treatment? But it's not a program primarily, even though it's advertised as a decriminalization program, as an alternative to incarceration. That isn't what it is. And so we need to be really careful in understanding what assisted outpatient treatment or involuntary outpatient commitment is in the context of this conference, because it's different from anything else we've talked about and what its real intention is.
Right, and thank you. I'm glad you brought that up. And in fact, going back to Richard's talk, there was a lot of attention post-Virginia Tech about AOT. And we've tried to be very careful in saying, yes, maybe you can reduce some of the everyday violence that you see in the lives of folks with mental illness, but it's not a remedy to gun violence. It's not a remedy to severe violence. You should only implement AOT if you want to improve these outcomes like reduce hospitalization, improve quality of life, but not as a violence prevention.
Yeah, there's other assumed group, South Never now client, not in Providence, Massachusetts, who are opposed to AOT, like Kendra Law and Laura's Law. And the reason that I'm opposed to it because a lot of clients feel that they're going to be forcibly treated. They will avoid seeing a psychiatrist. They will avoid actually avoid law enforcement officers. They avoid going to a clinic because they fear being treated against their will. And this is why a lot of clients like CFMC, NEC, Mind Freedom, other client group, client group, are both the LT. What would you tell those groups?
So we did a study in which one of the concerns we've had about AOT and the debate about AOT is that the people who are in the debate don't represent the actual people it affects. And so we did a study of representative people with schizophrenia, families of people with schizophrenia, clinicians who treat people with schizophrenia, and other policymakers. And the question we essentially asked is, if you could get the benefits, if you believe the data, and these are the benefits you could realize with AOT, would that be an acceptable trade-off? Would you give up this degree of civil liberties to get these benefits? And each of those stakeholders agreed that they would trade this off for these benefits. And it does make sense. I mean, if you're a homeless person living in New York City, and the AOT program got you to the front of the list for mental health treatment and housing, that's not a huge trade-off.
No. The Los Angeles has a Laura's Law program, an AOT program, under the current law. The only one that enforces it in the sense of involuntary petitions is Little Nevada County. But we have one here, and it is a strictly voluntary thing. It does deliver intensive services. The individuals who are in it arguably receive a higher quality and level of service than anybody else in the system. But they agree to it. They volunteer for it. And it's successful in terms of its own objectives, in terms of outcomes. Why bother with the involuntary part if you can do the same thing and get good results with a voluntary program?
So the only answer I'd give you, and I am not taking an advocacy position. We study this, so I don't want to engage it at that level. But we did show that if you got the premier treatment, which was assertive community treatment, and you got AOT, you did better. You had better outcomes if you got the assertive community treatment under AOT as opposed to just assertive community treatment alone. So there is empirically evidence that the court order is doing something. And could you do it some other way? I think it's possible. And actually, the former commissioner of New York, I thought, made a astute observation about AOT. And he said, what AOT does is it focuses accountability on all these systems. Because what the AOT team is doing, reporting to the judge, is it's calling all the providers and saying, did Fred show up? Is Fred getting these services? You know, there's a level of accountability over all the systems touching these people because we have, as you know, a terribly decentralized non-system. And what AOT does is focuses a point of accountability for the people under a court order. Could you do that some other way? Maybe. I think you might well do it. Could it be voluntary? Maybe, but there's no data on that yet.
There's a lady in purple right here.
Yes, ma'am.
How is quality of life defined and measured?
So in the study we did, we asked the clients themselves about their quality of life, and if they got a longer period of AOT, they reported greater satisfaction. It was using the layman quality of life interview.
Are we done now? You want to do one more?
That's not a more qualitative question. Is we often talk about the effect on the clients or even the families of being in coercive relationship. Power can be somewhat corrupting. Do we have any sense of what the effect on the clinicians or the professionals when you give us the power to make people do things? How does that affect our use of power, our collaborations, or the way we see people once you give us power over them?
By and large, when we've surveyed mental health clinicians about this, there's really very mixed opinions about this. There's a lot of clinicians that don't like the idea of this, don't like having this additional authority. And then there's some who, sort of reluctantly see the need. And I think it sort of breaks down that way, is that, it really depends on people's views of it. It's not a huge amount of authority. It's mostly cajoling. In North Carolina, all that happens is that if a person's non-adherent, you call the sheriff, and the sheriff picks up the person and takes them to treatment, and by statute for hopeful persuasion to accept treatment. So that's what happens. You get brought in by the sheriff to treatment. So it's not a huge stick. So there are clinicians who don't like doing that, but it's not, it's not forcible injections.